And I'm giving a countdown, so be ready. The timer would be visible on my screen once I set it. You need to see my screen. Whatever is on me, it will be visible on my screen. Okay. So you are ready?
Yes, ready.
Okay, I'm giving a countdown. Just a second. Okay, 5, 4, 3, 2, and 1. Here we go live.
Good afternoon, good morning, good evening to everyone here at the APOA. This is another exciting and really interesting area that we're talking about today in the big ideas in trauma care. And today's topic is tips in shoulder and arm injuries. This is a program that has been set up by the Asia Pacific Orthopaedic Trauma Association and an educational initiative by the Asia Pacific Orthopaedic Association. And we're very thankful to everyone that's contributed to put this together, and in particular to Jamal Ashraf, who has been very supportive behind the scenes in terms of facilitating its organisation. We have a wonderful group of speakers today, and I'd like to just briefly go through all of them and mention a couple of things to introduce them to anyone who's not familiar with them. We have Saeed Al-Thani. He's a senior consultant at the Mediclinic City Hospital and the OrthoCure Medical Centre in Dubai, the past president of the Emirates Orthopaedic Association, and the chair of the Education Committee of AO Trauma Middle East. We have Minoo Patel from down south. He's a consultant at the Orthopaedic at the Epworth Hospital. He's a professor at RMIT University, a senior lecturer of orthopedics at Monash University, and he's a past chair of the AOA Research Foundation in Australia. We have Sindy Vrancic, so he's a chair of accreditation at the Australian Orthopaedic Association and a consultant upper limb orthopaedic surgeon at Canberra Hospital in Canberra. That's at the Australian Capital Territory where our capital city lives. We have Ashish Babhulkar, who's the head of sports injuries at Thani Mangaskar Hospital in Pune. He's the organising secretary for the popular annual Shoulder Conclave and is the director of the Shoulder Fellowship Program of the IOA. And we have my good friend Therachai. He's the chief of orthopaedic surgery at Chiang Mai University. Hello, Therachai. He's an author of the AO Principles of Fracture Management and a master of the Mipo technique. And we also have our moderators, and I thank them for their time. We have Erica Colleen. She's a hand and upper limb surgeon in the Department of Orthopaedic Surgery at St. Carolus Hospital in Jakarta, and is also part of the Faculty of Medicine at the Universitas Trisakti. We have Dennis Yee, who's the Honorary Clinical Assistant Professor at the University of Hong Kong, an Associate Consultant in the Department of Orthopaedics and Traumatology at the Alice Ho Mu Ling Nethersole Hospital. And we have Mohammed Sufyan, who's a sports surgeon with a special interest in upper limb trauma and shoulder replacement, and an assistant professor at Liaquat National Hospital at Karachi, Pakistan. So welcome to everyone. I really do hope you enjoy the talks today, and please send through all your questions, as some will be moderated at the end of each talk and some will be answered towards the end of the session. So now I'd like to hand over to our first moderator, to Erica Colleen, to introduce our first talk. Thank you, Erica.
Thank you, Dr. Marinus. So the first talk will be a very interesting one. It will be delivered by Dr. Saeed Al-Thani from UAE, and the topic is managing the acromioclavicular injuries. Dr. Saeed, the time is yours.
Good time, everybody. And when we talk about acromioclavicular injury, it's a very common injury. It is happening every day to most of us. And And if we look at the learning objective of this talk, we'll talk about how to assess and how to treat the AC joint. So, as I said earlier, it's the second most common form of shoulder instability, and it's more common in male. Most of people get it through bike injury or slipping. Very few will get through trauma, car accident. There is a numerous of treatment modalities been there for a long time, like Bosworth screws and graft repair or weaver done. So we're going to look here at some point where we analyze the pathology and deal with that. So first of all, we have to assess clinically. We have to check if there is a sign of swelling, redness, if there is any instability, how much it's affecting the patient. And we have to check if there is any other pathology or any other injuries at the same time. We can obtain an image for comparison, comparing both shoulder, and we have to check for the CC distance and the position of the AC joint. And again, we can do with the Zanka views to show how far as the clavicle is above. Classically, we know that Rockwood classification, which classify them into 6. A problem with the Rockwood is there's a lot of difference and non-agreement between surgeon on the reliability of these injuries. And I advise everybody to analyze the pathology itself and look for there is stability or not, and patient symptom and his age, as well as what he do for living. So, as we said, there might be some other pathology. So we need to do some further imaging, like a CT scan or MRI. If you look at here, we look at the MRI, it shows a disturbance around the AC joint. As we know, MRI is a static view. It's not a dynamic view, but we have to rule out any other pathology. At the end of this presentation, I will share with you a couple of cases where we have to look for pathologies to understand the scope of or the scale of the injury itself. So when we indicate surgery, if there is a painful or persistent deformity, if there is a scapular problem or shoulder dysfunction, and if there is associated injury like slab or rotator cuff, anyway, you're going to operate on them, and so you better treat the pathology at the same time. So surgical option, in my hand, I prefer certain techniques, and that depends on how acute is the injury. If it's the first 2 weeks, I try to retain the CC distance with using suspensory fixation. I like to reconstruct and support both the conoid and the trapezoid branch of the CC ligament. So I like to have it fixed double. And if it is within 2 to 6 weeks, I will still do the same, but you might have to put in mind that you might need to do also some biological support with the graft if you need. Chronic, which is more than six weeks, I will think about maybe supplementing with the biological support like weaver done or using a hamstring graft to reconstruct. So when we talk about acute open repair, I like to put the patient in V chair. I mark my incision. I localize the coracoid. This is the round for the coracoid, and that's the width of the clavicle, usually about 3 centimeter incision. Then I identify, we split through the upper part of the deltopectoral, then we go down to the coracoid. Identify a drill with the guide wire coracoid after I clear both medially and laterally. Then we over-ream it. then I usually put two buttons on the coracoid and then the clavicle. And so then we pass it from through the clavicle and through the coracoid. If you look at here, I show two buttons. And this is the image of post-op. It's a simple technique. We construct the distance and repair the ligaments, and usually do very well immediately. Arthroscopic also can be done for this type with a P-chair and using a dead bone fixation, and or percutaneous, depends on surgeon preference and surgeon technique. This is another one where it was done percutaneously. Okay, there's an argument about arthroscopic approach. Maybe it's less invasive or better for coracoid visualization. I think it's also time consuming, and it's the learning curve for this. It's at the end of the day, it's a dealer choice between it depends on the surgeon itself and what the patient like. So rehab, I usually put them in sling for about 6 weeks. I allow them to do most of the activity by themselves. And then I start with active range of motion, 6 to 12 weeks, and then strengthening after 3 months. This is one of the examples that he present after he was a pedestrian, hit by a car, 36 years old, lawyer, and we looked at the x-rays and we tried to rule out other pathology, and we found that he has base of the coracoid fracture. In this case, if you try to put a suspensory fixation or you try to fix the CC ligament down to the coracoid, you will not have a fixed point because it is already displaced and it will fail. So in this case, we plan to do the stabilization, and we have to fix it. So we fix the coracoid with the screw, and then we use the graft to go around the coracoid. And if you, 1 second. If you notice, there's a 2-hole for the graft, which was sutured to itself in a figure of 8. For 6 weeks, then he started physio after 6 weeks. The second case, this guy was involved, 62 years old, involved in a rollover car accident, was intubated in the intensive care unit. He had a flared chest, which had ribs fixation. 2 months later, had a left rotator cuff repair. Another 2 months, he had the AC joint stabilization with the graft. He presented my clinic like 8 months after with this, where the AC joint still, regardless of the surgery. And if you look at it, he had this mark of the surgery where they use a graft, but the AC joint is high up there. So if you look at here, coracoid is broken. So this is a non-union coracoid that they tried to fix it too, so it didn't work. So this is where we talk about other injury that can happen in the same time. We looked at it. He also had some rotator cuff tear at the same time. So what we did, we stabilized the coracoid with a large cannulated screw. We used graft, and I augmented with a CA ligament in a form of weaver done, and we protect the repair with the hook plate. So this is the screw red in the coracoid, and this is the graft with the CA ligament crossing the clavicle and crossing the AC joint to cross to repair. We, of course, did did some distal clavicle resection. And this is the hook plate was used as a protection. And this is shows callus formation around the coracoid fixation, which is good for the patient, so that will avoid having stress on the fixation itself. So taking a message, we have to assess the AC joint with special views. MRI will catch other pathology, especially in elderly patient. Fixing both CC and AC joint will have a stable construct. If it's acute injury, you don't require any graft, especially in the first 6 weeks. Thank you.
Okay, thank you, Dr. Saeed, for the interesting talk about the managing of AC joint injuries. We have a lot of questions from the floor, and I will try to orchestrate the question one by one. Quite some time for our discussion. So, as we know, to manage the AC joint injury is very difficult, in my opinion. No consensus so far. So many papers, so many treatments were proposed, as you also mentioned in the talk. So I think AC joint surgery is still on its way to find a holy grail, just like the COVID-19 situation. So the problem lies in the grade 3 AC joint injury. As we know, there are two groups of surgeons to attack early or to give a conservative trial for this population. So in your opinion, what's your position on this? How to identify those patients may perhaps compensate to the...
I talk to the patient. I talk to the patient. I give him the choices and I assess him overall. The patient is not just an X-ray. He might be an engineer who uses his hand. He might be a sport or player. He need to have this fixed and he come back to his life quickly. That's the judgment between you and the patient. Okay. And you take it from there. Patient has to be the main factor in decision making. Okay, so you prioritize the history, the profession, and overall the patient-to-patient characteristics. Perfect. So for a follow-up question from this, we have one in the floor. What is your treatment option in the grade 3 AC joint dislocation in 60 years old man? Not the second case you proposed. I think this is just the AC joint without other injury. Is it really a good idea to operate? This is the first question from the floor. Well, depends on his function. Most of my patients here, 60 years old male, they are very tough man and they like to do things physically. And I think if it is painful, if it's affecting his life, I will do it. I don't have a problem with that. Okay, so age is not the major factor for decision making. So secondly, regarding the time of surgery, would you like to fix as soon as possible all the time, or you give a conservative trial? Well, in the first 6 weeks, I give them a week or two to think and to take their time. But I told them if it's beyond 6 weeks, then I have to do a bigger procedure to reconstruct and to gain the success. And that's their choice. If I think that you need the surgery, I will try to do it in a time fashion that's convenient and doesn't jeopardize his surgical options. Okay. Thank you. For the next question, there's a question from the floor regarding the fixation. Which is better in your opinion, the rigid fixation with implants or non-rigid fixation with grafts? Well, that's a question because you can have non-rigid fixation, not only with the graft, you can use it with suspensory mechanism. Depends if it's an acute or a chronic. If it's a chronic, you will need a biology support. If it's acute, you can get the suspensory Rigid fixation, I'm not in favor of the password fixation because it has a lot of complication. I'm also not in favor of hook plate, although when I need to use it, I use it. I think it's a pinch on the cuff and it requires a second procedure. Where the suspensory mechanism fixation doesn't require that second procedure.
Okay, this is quite interesting because we have another follow-up question, which is just about the same. They ask about the role of the hook plate in treating AC injuries. Many of these patients in my country also doesn't favor hook plate because they need a second surgery, which is, I think, is an additional cost. And let's move on to another question regarding the CC ligament repair. So this is quite interesting. Some of us perhaps believe that the CC ligament will compensate or will heal in acute setting. Some did not or doesn't. The CC ligament reconstruction, of course, there was a lot of pressure from the markets. So in your opinion, do you believe that the CC ligament will heal by itself in acute setting, or it's like an ACL? You don't believe ACL can repair itself, so we always do ACL reconstruction. Your opinion, please.
Well, if you try to do with the fixation, like with the suspensory mechanism, the soft tissue, you will allow the soft tissue to heal. Okay. And even if there's some scar tissue will form at that point, but that's still acceptable. And that's, I haven't seen any patient over the last 15 years who have an issue with our failed primary fixation. I haven't seen, at least in my hand.
Okay, so there is still a chance to be repaired. And regarding the graft that I saw the first patient or the second patient of your cases, you use a hamstring graft, sir, for this?
Yes.
Yeah,
yes.
okay.
I use the gracilis.
Okay. Why don't you choose a Semity? Because it's bigger.
I keep the Semity for the ACL.
I see. All right, that's fair enough. Okay. In my country, there is no synthetic graft so far. I live in Indonesia, and I think there's synthetic graft is available in UAE, sir. What's your opinion on this?
I'm not in favor of synthetic graft. I don't use them. I haven't used them in my career.
Okay. So regarding the open repair, so I saw in your presentations, you described 2 ways to repair, open and scope. Okay, I think not many of the young surgeons are very comfortable doing open repair as because of the concern of the deltoid dehiscence. I want your opinion on this issue, how to make an incision or approach in order to avoid deltoid problem, the anterior part especially. Your opinion, sir?
Well, if you look at my slides, I made my incision medially. And when you make this, the skin incision went down to the deltopectoral, I go to the proximal part of the deltopectoral approach and I retract at that point. And I keep the deltoid attached to the clavicle. So when I pass I work under the deltoid and above the deltoid for my tunnels on the clavicle.
I see.
So I always keep the deltoid attachment intact.
Okay. So preserving deltoid is the key for the excellent outcome. Okay, we have 1 minute left. We'll ask the final question here. I noticed in your slide you do use Zancafil for your diagnostic imaging. Have you used any cross abduction X-ray to check the horizontal instability? Or is there any way to, do you use any intra-op evaluation in your experience, sir?
Well, I made my decision before they come to the OR.
Okay.
And so that's why I made my decision before, and I just come to execute. But you see, one of the things good in the surgery, you try to minimize your time in the OR by avoiding repetitive or unnecessary techniques. You already made your decision, you can check it, but go and recheck and recheck. That's slow, your procedure, that's one. And then it will expose the wound to air more, and that will risk infection. You have to be sharp in your decision and you execute what you planned before surgery.
Okay, absolutely agree with you, sir. I think the time is up. Thank you, Dr. Saeed, for your talk. And it's a nice Q&A with you. I enjoyed the session. And over to you, Dr. Marinez.
Thank you.
Thank you.
Thank you very much, Dr. Erica. Now I will be introducing the next presenter, Professor Minoo Patel, and he will be enlightening us with his talk on clavicular fractures, when and how to fix them. Dr. Minoo Patel, please, sir.
Hi, thank you very much for the invitation. So we're going to look at clavicle fractures, and we need to decide not just how to fix it, but actually the more important question, when to fix it. It's a very topical question. And the pendulum has really swung quite a lot. 20 years ago, we wouldn't even have a session on clavicle fractures, right? Because you never operate on clavicle fractures. They all heal. But of course, now we've come to a situation where some people say you should operate on most clavicle fractures because of the risk of non-union or malunion. And the truth is somewhere in between. So this is the paper that really stirred people on the clavicle fractures. This is the multi-center study from the Canadian Orthopaedic Trauma Society. This is Mike McKee and Emil Stam's paper in 2007. But exactly 10 years ago, Hill, Maguire, and Crosby in the British JBJS produced a similar paper. And it tells you how fashions can change. Probably in those days, we still didn't have fancy clavicular plates, and this paper flew under the radar, even though it came with the same conclusions that close treatment of displaced middle third clavicle fractures gives poor results. So what did the COT study show? It showed that in the surgical group, you got better constant scores, better dash scores at all time points. The mean time to radiological union was less than half. And that's very important when you have a young person who wants to go back to work, cannot take time off work. Non-unions, significantly less, and equally importantly, symptomatic malunions, significantly less. And we are talking about neurological symptoms, weakness, etc. Equally importantly, at 1 year after the injury, the patients in the operative group were much more likely to be satisfied not only with the appearance of the shoulder, but also with the shoulder in general, the function of the shoulder. But of course, there are complications. And in the COT study, most of the complications were hardware related. You had local irritation and prominence of the hardware. And as Dr. Thani was talking about the hook plate, most clavicle plates, patients will elect to get them out. So that's a secondary procedure. You also have to worry about wound infection and mechanical failure. So which clavicle fractures warrant fixation? There's no doubt open fractures require fixation, patients with neurovascular compromise, and a floating shoulder. Also, I believe lateral clavicle fractures should be fixed more often than not. Clavicle fractures with a CC ligament injury, and that's where the Rockwood classification really is not very accurate. Sometimes you get skin at risk, and I've seen a couple of young ladies where the bone fragments are tenting and the skin is white, and you're better off fixing these. But what about the common fracture, which is the midshaft fracture? So if you look at Robinson's paper from JBJS in 2004, he tries to calculate the risk of non-union. So the overall risk of non-union, according to Robinson, at 24 weeks is about 6%. Medial end fracture, about 8.3%. Lateral end fracture, about 11.5%. But the midshaft fracture, he calculates at about 4.5%. And what does it tell us about which people are more likely to get a non-union? Females, patients over the age of 60, displacement, meaning loss of cortical contact, comminution, so these are high energy injuries, and of course, smokers. Then we go to Murray's paper in 2013, and he looks only at adults over the age of 18, And he talks about a 13% risk of non-union in diaphyseal fractures. Again, smokers and high energy injury. And then this is the Cochrane review. And this group is extremely conservative. And Ivanu, who did the review in 2014, he speaks about between a 15 and a 20% risk of non-union. Now we're talking about significant risk. 1 in 5 or 1 in 4 is going to get a non-union. So how can we decide at day 0 who are the ones who are going to get in trouble? And the only clinical prognosticating sign seems to be pain. And this is Quist's paper from Clinical Orthopaedics this year, where he talks about minimum pain decrease on the visual analog score from 2 weeks through to 4 weeks signifies that this patient is going to go into non-union. Also, in absolute terms, at the end of 4 weeks, if your VAS score is greater than 1, there's a relative risk of almost 18 of getting a non-union. But even more importantly, if your VAS score is increasing, then the risk of non-union at 6 months has an odds ratio of 1.8 for every increase in the VAS score. So if your patient is consistently complaining of pain, that's a bad prognostic sign. But at the end of the day, we're not going to operate on all clavicles. So we look at something called as number needed to treat. So how many do you have to treat to stop one non-union? And again, the figures vary. Some studies say 4.8, some go to 10, some go to 18. Axelrod, who's from Mohit Bhandari's group, they did a network meta-analysis of 22 RCTs, which was published in Core. And they talk about a number needed to treat of 8 or 9. So what you have to tell your patients is that you got a 1 in 10 chance of getting a non-union. And in your mind, you only have to treat 8 or 9 patients to avoid that one non-union. So for surgery, that's a very significant number needed to treat. This is from Ortho Evidence, also from Mohit Bhandari's paper. It's a slightly complex slide, but if you look at this network meta-analysis, this is a non-union forest plot. Non-unions, definitely better with surgery. Malunions, again, definitely better with surgery. So as it goes to the left, that's a significant improvement. Delayed union, not quite much. Other complications, of course, surgery comes into picture and your complication risks are about the same. So what happens when this happens?
Oh, you right?
So these are the patients who like, shooting themselves when they're getting these falls. This is a fracture. So how do you tailor your treatment to the particular patient? It's a young patient. It's a high energy injury. There is very poor bony contact. This guy is going to be a higher risk of a non-union. Plus, it's on the lateral aspect of the clavicle where the blood supply is poor. So when you talk about stresses on the clavicle, there are 2 types of stresses. There's a cantilever stress where the clavicle is fixed to the medial end. And when you abduct your shoulder, that's a cantilever 3-point bend. But equally importantly, when the forward elevation movement happens, there is a torsional stress. And it's important to remember because bones, being hollow tubular structures, are weak in torsion. Now, when you talk about clavicle fixation, there are 2 types. There is intramedullary and extramedullary. Intramedullary can be with flexible pins. There are the so-called rigid flexible, like the Sonoma pin, where you put them flexible and then you tighten the screw and it becomes rigid. Or you can use simple screws to have a rigid intramedullary fixation. The problem is it's a curved bone and you're trying to put a rigid implant into the medullary canal. So with medullary screw fixation, the advantage is it's a smaller incision. You can find the fracture. And then what you do is you open the canal medially, laterally. You put an intramedullary wire which comes out laterally and it comes out right at the posterior aspect of the AC joint. And then you retrograde it. And then you reduce the fracture. And you can do it with a relatively small incision. And my very good friend, Martin Richardson, who's our current AOA chairman in Australia, he is the pioneer of this Herbert's technique. He's done 2 papers. This was his earliest paper. Excellent results, very few non-unions. That's the Herbert screw. And now I'm trying to convert him to using the CCS screws. They've got a much smaller bevel and much sharper cutting tip, and it's much easier to use this surgery, even with comminuted fragments with these inferior butterflies, which you can use a suture technique for. Then you come to the extramedullary fixation, which are the plates. And in terms of plates, you got two options. The standard AO teaching, you can have either absolute stability, and you see absolute stability in the picture on the bottom, where there is an interfragmentary screw and a superior plate. You can also put anterior superior plates, or you can use anterior plates and get the similar result. The other option is to go for relative stability, which is what my preference is, a standard bridge plate. And you get this comminuted fracture. You can see the suture loop that we use for the butterfly fragments. I often will use a temporary intramedullary wire to hold it into place. But the other important thing you see here is that there is a very strenuous attempt to keep all these screws unicortical. And you see that at 6 weeks on the picture on the right-hand side, there is good union because we have kept the biology intact. We haven't stripped the bone of the periosteum. So this is what I was talking about. You use an intramedullary wire temporarily. And also when you have butterfly fragments, you just use suture loops so that you get biologic fixation and you get callus formation and you get bony union. This is what we've now perfected doing. We use what we call as a hybrid fixation. We use oblique unicortical screws, which are cortical screws on the ends, which get very good purchase, seat the plate down, and then we use locking unicortical screws. The problem with the multiplanar curve in the bone is you get all sorts of plates. You've got plates that go superior. You've got plates that go superior on the lateral side and anterior on the medial side. And then, of course, plates with smaller screw holes for the lateral side. Here's another case where we've got a lateral fracture. And again, we've kept the middle segment with the comminuted bits intact in terms of not putting screws through it, just using the plate and then using circular sutures to keep everything in place, and you get good callus formation and union. So why unicortical? Well, because iatrogenic neurovascular injury is a catastrophic complication. Nobody needs to die having a clavicle fracture fixed. And we've had one death and a couple of near misses in our country over the past 6 to 7 years. And Greg Bain, along with Zoomstein and later with Galley, produced these papers which showed essentially in the central portion, the vessel is at risk anywhere, whether you go from anterior to posterior, whether you go superior to inferior. And the vessel that will kill you is not the artery, it's the vein, because if you nick the vein, which is often with the drill bit, when you plunge on the other side, you get an air embolus and you can have very, very rapid fatality. Plus, of course, you've got the brachial plexus on the other side. So if the screws were not to penetrate the far cortex and still get the same stability, that would be a much safer technique. And we've now got 3 papers looking at our unicortical technique, either with locking screws or hybrid screws. And we've got a standard model which we can now use. And these are the constructs, unicortical locked, unicortical hybrid, or bicortical locked. And this is the torsional testing on the left and the cantilever bend on the right. And what we found in general was that the plates will definitely give you a better rigidity to the fixation compared to intramedullary. You can start your mobilization straight away. But when it comes to unicortical versus bicortical versus hybrid, no difference in torsional stiffness, no difference in bending stiffness, and no difference in the ultimate strength. And so our first 45 cases, which we presented recently, we got union in all except a segmental fracture where the medial side didn't heal. But more importantly, even when it did not heal, there was no failure of the construct. Very good dash scores. But a word of caution, unicortical fixation does not work with anterior plates. Lastly, I want to talk about lateral fractures because there's some good information coming out about these fractures. And if you look at this particular fracture, there is displacement. There is very poor bony cortical contact, and this fracture has a very high risk of going into non-union. And my choice in this particular case is to use both the suspensory fixation as well as the hook plate. But if you notice the hook plate, this particular hook Sorry, I don't know what happened here. So this particular hook is inclined down. So this is the plate from Stryker. It's a titanium plate, so it's more flexible. And the inclined hook, which is at about 15 degrees, is much more kind to the rotator cuff. And this is now my go-to plate. Also for lateral clavicle fractures, you've got to get at least 3 screws beyond the coracoids. So we'll use a longer plate, preferably a 5-hole plate. So this is the technique. I do my coracoid-clavicular suspension just percutaneously with the image intensifier, which is what I use for the AC joint as well. You deploy the button. This is the toggle lock system, and I use the dog bone, as Saeed mentioned. And then you go ahead and put this plate. So when the plate comes out, you still got your insurance policy in form of the suspensory ligament. This is a very, very good review in Journal of Shoulder and Elbow Surgery International, came out last year. And it showed that a locking plate, whether it be a locking hook plate or a standard locking plate that I showed earlier, with a CC stabilization is much better than just K-wires, just tension band wires, just CC stabilization alone, or a hook plate alone, or an LCP alone, and definitely better than non-operative treatment for the treatment of lateral clavicle fractures. So my recommendation now would be to use some sort of locking construct, preferably a hook plate, along with a suspensory construct, and your plate can easily sit on the CC stabilization over the button without jeopardizing anything, and that can stay in place when you take the hook plate out. There are plates where you can put a button through the plate. The problem is when the plate comes out, if you have to take it out, then your suspensory ligament has to go as well. Lastly, I want to touch on double plating and the masculine technique. Unfortunately, we're seeing more and more infected non-unions as a result of fracture fixation. And if you look here, these 2 screws are already loosening up. This man was fixed in Peru. He came back. He had infection and pain. He grew C. acnes and staph. This is what it looks like once the plates were taken out by another surgeon. And that's what it looks like on the CT scan. And when we did an MRI scan, about 1.5 centimeters on either end was essentially dead bone. And so what we do is we excise the necrotic bone, and then we use double plating techniques, a superior plate and an anterior plate for rigid fixation. And then you use an antibiotic cement spacer, which generates the induced membrane. At 6 weeks, you take the anterior plate off, you can incise the induced membrane, take out the bone graft, and then put cancellous bone graft in it. And that goes on to unite. And you can see here very nicely, there is complete union and the infection has been eradicated. So this is biplanar technique. And if you have an uncooperative patient, you can also use biplanar techniques to stabilize the fixation. So in conclusion, there is a greater likelihood of union at 1 year with fixation, but functional score improvement just about reaches the MCID. Constant score does, the dash score doesn't. The number needed to treat is roughly 9 or 10. With surgery, the most common issue is secondary surgery for metal removal, but remember, neurovascular structures, and therefore preferably stick to unicortical fixation. The other important conclusion, and this is from Ortho evidence, is that with the non-unions, they are much more difficult to manage than a fresh fracture. And this is something that you have to tell your patient, that it's not just a 10% risk of non-union, but that the risk of managing that non-union will be more difficult. So it has been calculated that about 20% of these non-unions, when they're treated secondarily, will persist as non-unions. So overall, it's a nuanced discussion. As Saeed said, you have to sit down and chat to your patients. Ultimately, it's the patient's body, and they get to make the choice of whether the fracture is fixed or not. Thank you.
Thank you very much, Professor Minoo, for an excellent and enlightening talk. So coming to the questions, there are quite a lot of questions from the house, but in the due course of time, I think will be asking a few of the questions. So, as you said that your approach is towards the bridge plating, and you are actually more concerned with the healing by callus formation. So, do you have any experience in or any results regarding the Mipo technique regarding the fixation of the clavicle for your clavicle fixation using a plate?
Well, I mean, depends on what you mean by Mipo. Most of the time you make small incisions and then you work underneath, on either side, underneath the skin. You can retract it. There is a technique that David Duckworth has described, and this is for plates, that is, where he makes 3 different incisions and he puts the plate through. When I take my plates out, I use only 2 small incisions on either end. But, you know, at the end of the day, you want to get a good job done. Just because you incise the skin does not mean you are disrupting the blood supply. You still respect the biology. And, you know, at the end of the day, incisions healed side to side, not end to end. So I make an incision as necessary. It's certainly much smaller with the intramedullary fixation.
Thank you very much. One last interesting question. You started up with an excellent literature support. So there is a question that in literature, why have recent studies reported a higher non-union rates as compared to the earlier studies? Professor Minoo? Professor Minoo, can you hear me?
Sufyan, he may have dropped out, so we may just continue if that's okay, and we can come back to it at the end if you like.
Okay, as Professor Minoo, I think he has dropped out. So I would be like to hand over to Dr. Denisi to present his next lecture. Thank you. Over to Dr. Dennis.
Okay, thank you very much. So we have 2 excellent lectures, but we have more to follow. Okay, so the next speaker is Professor Sindy Vrancic, who will talk about humeral head fractures. Okay, the floor is yours.
Thank you very much. Just sharing screen. And there we are. So thank you for inviting me here tonight. My first time joining all my friends around the world. I'm an upper limb surgeon here in Canberra, and for those of you who don't know, Canberra is actually the capital of Australia. Firstly, I have no declarations and no industry support for this today. I work at the Canberra Hospital, and we are a tertiary level hospital, and we drain around 600,000 people in the middle of our region. And Canberra is halfway between Sydney and Melbourne, for those of you. We are known as the bush capital, and just to prove that, the photograph on the bottom right is actually on my front lawn of the kangaroo who eats my lovely grass. My role today is to talk about some tips for management of the complicated 4-part proximal humeral fractures. When we do trauma, we get a little bit carried away sometimes with the complexities, and I want to draw you all back and go through some more of the simple tips to help get through any of these complicated fractures. Number 1 is think twice, maybe 3 times before deciding to fix these fractures. We really must choose our patient wisely, as outcome is often related to our protoplasms that we operate on. We also need to choose our surgeon wisely. Are we the best person to manage the fracture? There are a wide variety of implants, and when we choose our implant, we have to understand why we are choosing the implant and what we want from it. We really do need to understand the fracture and take your time, because these are not a quick procedure, and keep it simple. The general trauma community impressions for internal fixation of proximal humerus fractures is that we do get consistently high, relatively high complication rates. The revision outcomes are often unsatisfactory, and we've had randomised controlled trials that seem to show no benefit from our internal fixation versus non-operative. But we do need to remember the independent factors for failure are the age, bone quality, and functional demands of our patients. And for this talk, we're actually talking more about the younger patient. So how do we actually choose the right patient? This article is due to be in press shortly and is trying to give us an algorithm of how we choose what operation for which patient. In this paper, they define young as anyone less than 65, healthy and a worker. And in this population, the algorithm suggests that we offer internal fixation for these patients. Now, with our young patients, how do we get the best outcome for them? The most important factor I've found is we really must educate the patient first. We always have to attempt to fix and then deal with any consequences later. As with the other implant procedures we've heard from tonight, we may need to remove the plate and we may need to release some scar tissue later, but the primary role is to get bony union. Our patients need to understand this is a significant fracture and they are unlikely to regain normal movement. We often come to conferences and we see fantastic x-rays and videos of patients who do fantastically after this procedure. But I've got 10 patients who don't versus the one who has that fantastic outcome. They're better than non-op, but we do have to align their expectations with what is likely to happen to them. And in our younger population, stiffness seems to be more of a problem. We need to educate them that keeping their own articular surface is almost always better than anything artificial we can give them, and it will take them 12 months to get over the injury. But what is young? Does it depend on the reflection in the mirror as what we decide is young? The steps of management for complex proximal humeral fractures are the same for any complex trauma. We've already discussed choosing the patient. We have to choose the time. These fractures take a long time to fix. The setup time alone often takes 45 minutes to an hour. So this is not an operation to be done at 6 p.m. on a Friday night if we can avoid doing it. We will talk a bit later about choosing the implant and what sort of technique we use. But with all complex fractures, it's the same technique. We just need to reverse the displacement, restore the alignment, maintain it, fix it so we can move it early and minimise some complications. My first tip is the setup. For those non-shoulder surgeons, in my hands, every time I do one, it's a beach chair. I'll use a T-Max and usually a general anaesthetic with a block if possible. The Chlorhex 2% with alcohol prep, as C. acnes loves to live in our armpits. I usually put a strip of local anaesthetic with adrenaline into the skin to help with hemostasis initially. And I always use a beach chair drape with a pouch, as I do tend to drop things and the pouch is very helpful to catch it for me. I free drape the arm and just like this picture, I like to leave the elbow exposed so I can feel the epicondyles to help with my alignment and rotation. And I use a Mayo table for support, but certainly using a spider attachment or a second registrar assistant is also reasonable. I prefer just one, it gets a bit crowded. And almost universally, I will use a deltopectoral approach for my 4-part proximal humeral fractures. For our shoulder surgeons, using standard instruments every time makes the exposure so much easier. For those unfamiliar, this is what I have always. My Gelpi retractors, potentially a Brown's deltoid retractor, link retractors with different size blades to deal with different size arms, Darracks, my Heaney curved needle holder, and a braided suture. Every fracture, I use this standard setup. Now, one of the hardest things with doing these fractures is where to put the image intensifier to get the best x-rays intraoperatively. In my hospital, picture A would never be allowed because the anaesthetic team hate to have the machine in their area. So I use image B, where the image intensifier comes in parallel to the bed from the head of the patient. This is a very nice article which goes through some fluoroscopic techniques, and I'll be sharing some of that with you now. The best way to get the views is to move the arm and not to move the II machine. In the first picture here, we can see with the arm externally rotated, we get a great view, what's called the screw view. And in B, it's where we internally rotate the arm and we can get a view of the plate. So the screw view is this view, and it allows us to assess the length of all of our screws. We can assess the articular surface in relationship to the glenoid, and if the plate is positioned properly, we'll only see the edge of the plate. This is where we can assess our head shaft angle and make sure our plate is in the proper position. Then when we internally rotate the arm, we get the plate view. And on this view, we should see the whole plate, and it looks like a light globe. So we can see the humeral head, and we can see that the head is normally aligned to the shaft. And it's on these views we can see if our screws are too long, if we've penetrated through, and assess for any malrotation of the tuberosities. Two very simple ways of getting great views of our fixation. For tip 3, we need to understand the deforming forces, and in every fracture, the proximal humerus breaks the same way. So why do they displace the way they do? The head doesn't have any attachment, so it can go anywhere it likes. The lesser tuberosity, and the head is often attached to it, will always go medial and inferior thanks to subscapularis. Our greater tuberosity will always be pulled proximal and posterior. And the shaft of the humerus is pulled medially and superiorly, which leads to our varus deformity, thanks to pec major and deltoid. So when we understand the deforming forces, we can then understand better how to reverse them to realign the proximal humerus. This is my most important tip, I believe, for managing our proximal humerus fractures, and that's including cuff in our reconstruction. So before I start, I always place cuff sutures. Even in my 2-part fractures, it's just habit now that we put non-absorbable sutures throughout the cuff. Tagging the fragments with sutures allows us to mobilise them during the case, and then we can manipulate the fractures back into place. At the end of the case, these sutures help counteract the deforming force of the cuff and add stability to our construct. Now, I've seen some great videos of surgeons who place all their sutures before the plate gets attached to the bone. I'm not that good. I put mine through at the end with either a free Mayo needle or a suture passer. There are some studies out there that do show that adding supplemental suture fixation does add strength to the construct and minimises complications. How do we maintain the reduction? Now, I'm not that fond of this tip and I don't do it often, but it is in the bag of tricks when we're struggling. The humeral head, when it's not attached to any of the other fragments, is difficult to reduce. KYs will be your friend. We can use the supraglenoid tubercle as a guide to where the humeral head should be sitting, and we can feel that through the rotator interval. We can use the glenoid as a reduction template, and we put the humeral head against the glenoid, and we can gently pin it. But we must remember, if you're going to use this technique, you cannot move the arm to take further shots. Wire breakage in this position is not fun to deal with. So if I have an unstable head, I will certainly pin it to the glenoid, reduce the tuberosities, and then remove the pin from the glenoid, leaving it in the humeral head. We have to understand our implant, and there are a lot of them out there. Now, I've put some of them up here for observation to note specifically that they all sit somewhere different on the proximal humerus. They all have different philosophies. They all have different screw holes. And so when you choose your implant, it is vital that you understand where it is meant to sit on the humerus to get the optimal fixation from your device. I haven't seen any studies that confirm that one is so much more superior than another. So I don't think the plate itself is the key. The key is how we use it, where we put it, and more importantly, where the screws are. So we understand the basics of locking plates in the humerus. The plate goes lateral to the bicipital groove. It is a small fragment plate, and we use locking technology for better fixation. It is important to utilise the multiple screw directions for better purchase, and the medial calcar is the key. Now, the plate can always come out later. Our goal is bony union. If it's not perfect on the bone, the position of the plate, as long as it heals, we can get it out later. And in young patients, the plates are optimal. One of the biggest problems, however, with our proximal humerus plates is we tend to put them too superior. And this will lead to impingement, which is probably the most common issue in our younger patients. I do recommend using the guides that are on the sets, and often they'll have a K-wire hole, which will help position the plate inferiorly enough to avoid impingement. So again, it's important to understand the plate that you are using. Make sure you check with the image intensifier. I always put my plate too proximal to start with. So using the oblong hole, having our non-locking screw in the proximal end of the pole, in the distal end of the pole, so we can move the plate down. But even more importantly, tip number 8 is choose your screw holes wisely. I always thought they put lots of screws there because they wanted to sell us lots of screws, but there's actually a reason why the screws are there and for their configuration. And this paper actually goes through the different screw placements and the failure of fixation risk. The red screw here, the calcar screw, the medial calcar screw, is the most important screw of them all, in my opinion. But which holes do we use? Which ones are the strongest? What configuration? What is the near-far technique? And so when we look at these holes, and from this company's one, we can see that there are 5 rows of holes. If you decide you are only going to use 4 screws, then this paper shows us that the strongest fixation is in row A and row E. And row E are your calcar screws. And this is like an internal X-fix. It's your near-far technique. So if you only want to put 4, then please use those 4. If you decide to just use 6 screws and you choose the top 3 rows, that is the worst possible combination you can use and the most likely to fail. If you only want to use 6 holes, then every second row is the strongest. But it is even better if you use all 8 or 9 holes on the plate. The pictures down the bottom show the different configurations depending which screw holes you use. And so if you understand your fracture and what you're trying to achieve with your screw placement, you'll be able to catch the fragments as per your fracture. So choose the screw holes wisely. Don't just randomly fill whichever ones you feel you want to. What are the complications of our proximal humeral fractures? We've all seen them. The articles have quite a high rate of failure and complications, can be up to 40%, which is extremely high. Revision surgery rates can be as high as up to 25%. A significant component of complications are actually surgeon issues, so non-implant related, malreducing the fracture, screws that are too long or too superior and cutting out, malunion, non-union, 13%, quite high, avascular necrosis in the proximal humerus, around 16%, and infection risk is quite high, up to 5%, and this is linked to an increased operative time. There are also implant-related complications where we get secondary screw cutout if osteonecrosis occurs around the screw, glenoid destruction if the screws are too long, hardware breakage, which only occurs if you have a non-union, and if we have inappropriate screw length, we have implant complications. We also find that the complication rate may be higher in the younger population. Is that because we're pushing the boundaries in the fractures we are choosing to fix? Do our patients have greater expectations? Are we seeing a higher complication rate or a higher revision rate because we're more likely to offer further surgery in this patient population? And our younger patients are more likely to want to have elective implant removal, despite the studies saying that removing the plate often doesn't actually improve their range of motion. So the high-risk group are smokers. We were traditionally taught it was the alcoholics or the time to surgery, but that seems to have no impact on outcomes. So in summary, for my tips for complex proximal humerus fractures in the younger patients, standardise your setup. It makes you more comfortable and improves your view during the case, and use X-ray to your advantage. Understand the deforming forces and always include the cuff repair into your construct. Maintain your temporary reduction, understand your implant, watch where you put the plate, choose the screws wisely. Thank you.
Thank you very much for your excellent talk. I think all the audience will enjoy it so much. So maybe I start by some questions. There are actually a lot of questions coming to you. So maybe can you talk about the role of the calculus screws? I mean, you have talked about how we should choose the different pattern, but do you put in calculus screw in all the cases? Is it optional?
No. I don't believe it's optional. That's our way of preventing collapse of our fracture. And one thing I didn't go into, and there's a vast amount of literature on it, is supplementing the medial calcar with either a strut or another plate. But the calcar screws are vital for preventing collapse of our fracture. So yes, I use the calcar screws whenever I can.
So even if there is a medial or cortical contact, you think calcar is still very important, right?
There's no harm.
Okay.
As long as you don't penetrate. So once again, it's important. One of the hardest things of the proximal humerus is it's round, and it's very easy that the screws look like they're in on one view, and on another view they're out. So we always must balance our screw placement length with what we want out of them. But yes, calcar screws for them all, please.
Do you do bone grafting in elderly or synthetic bone graft?
And so I've limited this to younger patients. So I think older patients is a whole different ballgame with regards to allograft, autograft, cement, struts. It's a whole nother talk. So I could talk all night, but I generally don't tend to use it in the younger patients.
Okay. How do you choose between replacement and fixation in the 4-part fractures?
Again, in the younger patients where possible, I'll do my best to fix as much as possible. Head splits are one area where I will start the case attempting to fix, but may have to convert to an arthroplasty. But in my younger patients, fix wherever I can.
Okay, that's very reasonable. Have you tried IM now in a proximal humerus fracture? I mean, any experience to share?
Oh, yes. So I'm not a fan of intramedullary nailing. I'll use it in the pathological fracture in the elderly patients. I've had probably most of my complications from humeral nails, perhaps technique related. I'm also, as a shoulder surgeon, it hurts me to go through the rotator cuff. When I spend my life repairing rotator cuffs to put a big hole through the rotator cuff, I know I can fix it at the end, but it bothers me.
So not in 4-part, right?
I wouldn't attempt it in a 4-part. I'm not. So when we talk about choosing the implant, it's something you have to be comfortable with, and I'm not comfortable in a 4-part putting a nail in.
Okay. Do you use intramedullary fibular grafts? I mean, it's one of the techniques to put a fibula or even one vertebral blade in the IM. Do you use that technique?
No, I don't use that technique.
Okay.
But there may be some other panel members who do.
Okay. So I think one of the last questions will be, do you arthroscopic arthrolysis common in this type of a patient? I mean, sometimes they have a frozen shoulder.
I think yes, it's a difficult thing. Is it stiffness? Is it capsulitis? Is it both? I don't tend to do an arthroscopic technique often. If these people have stiffness, I think it's reasonable to take the plate out as well as do a release. So while I'm taking the plate out, I'll do an open release of the bursa per se, but I generally don't go and do any capsular work in these patients.
Okay, thank you very much. I think we all enjoyed your talk so much.
Thank you.
So maybe we can pass on to the next speaker.
Okay, thank you, Dr. Dennis. After the concise talk about the ORIF or proximal humerus fracture from Dr. Vrancic, the next speaker, who is Dr. Ashish Babhulkar, is one of the prominent shoulder surgeons in India, even in Central Asia, who does not need any introduction, I believe. He will talk about the role of reverse shoulder replacement in humeral head fracture. So, Dr. Ashish, you will have 15 to 16 minutes for your talk. Over to you.
Thank you, Erika. And thank you, Marinis and Jamal, for this opportunity on behalf of the Asia Pacific organization. I will get going. Is my voice audible?
Very good.
Yes.
Yeah, lovely. So firstly, we must clarify that we are dealing with fresh fractures or the sequelae of delayed, malunited, or failed fixation, because the results are chalk and cheese. So there are diverse outcomes between both the groups. So it's important to understand which one to pick first, and it's best to do these surgeries as index surgeries, because a reverse shoulder as a revision case is not going to give you the same results. In fact, the complication rates are higher with delayed surgery in sequelae. And certainly, as proven, the tuberosity healing rate and the external rotation restoration is much better when you do these reverse shoulders as a primary opportunity for treating proximal humerus fractures. Unfortunately, a lot of these fractures, because they go bad, the reverse shoulders looked at as the salvage option, but then they don't represent the key understanding. So this is one of my patients, the first patients I have done, 81 years old, 3-part fracture, fairly intelligent, active lady who understood everything. And we offered her after a week, and you can see that it depends on which view you decide, because you need to understand that you should have the service of 3 different views to decide whether this fracture is going to be stable or is going to collapse. And no point waiting for it to collapse after 6 weeks and then offering a reverse shoulder when everything has scarred up. So we think 3D CT is mandatory, and once you do this, of course, they're going to do well. I'm sure some of these patients would do well with a fixation, but one can never judge the quality of the bone. And sometimes it's like an empty eggshell, and you go in and you're not planned, and you're forced to do a fixation for these ladies. So there's nothing wrong in doing a reverse shoulder primarily, and to give them that one last shot so that they can get their function back. Often you can have these elderly people having good looking x-rays but poor function if you end up fixing them or doing hemiarthroplasties, and that certainly is a strict no-no for this age group for sure. So does that mean that the hemi is extinct and not to be used? So I have several senior colleagues in Europe who just refuse to use the hemiarthroplasty, and thankfully I'm not one of those. So I still have hemiarthroplasty as a decent option for some of the difficult ones. But we're dealing probably with acute fractures in patients who are 75 years and older, whose bone quality is suspect. And more than that, it's very likely that their rotator cuff is of a poor quality, and knowing that the prevalence of rotator cuff tears is high in this age group. Obviously, if you look at the literature, the comparison between the reverse versus the hemi, the reverse does score much higher on all the shoulder function tests. There's a higher satisfaction from the patient side. The complication rates are fairly similar, but this paper from Cuff et al. 2013 does not mention about the age of the patient, what is the restoration of the rotations, which are rather poorer with the reverse shoulder patients. And of course, there are cost implications. So what I say today will probably clearly apply to somebody who's 75 and over. And then you have to be very picky and selective on those patients who are younger than that and who deserve a reverse shoulder. So you have to be very alert. Now, that's one thing that you don't want to do. And even I'm gutted to offer a reverse shoulder to somebody who's 45. But this clear example in a diabetic lady, this is a gentleman who, one of our colleague surgeons saw this X-ray, and clearly it's a 4-part fracture dislocation, a very difficult fracture to treat. And this was his post-op X-ray. Obviously, it was a very poor representation of open reduction internal fixation. So his senior colleague within the 6th day post-op told him, this is not going to work, we need to revise this. And they quickly jumped the bandwagon and put in a monoblock prosthesis. Now, if you watch closely here, the GT is flying off already. And so it is disingenuous to do this kind of stuff, especially in inexperienced hands. And if the GT is gone, even if you do a plating, even if you do a hemi, it's game over. It's all or none. So we respect the GT, we worship the GT, and it's very important. She came to us 3 years later with a complete drop arm, and then we had to do this kind of revision in a very young patient because we're compelled to do that. And again, the GT is missing here because it was so scarred down to the posterior glenoid, there was no salvage. So this is her presentation on day 1 when she came in 3 years after her hernia arthroplasty, and she had terrible pain. And this is her representation about 2 years after we've done her reverse shoulder replacement. And she's significantly pain-free. We have managed to restore her range of movements. But again, I keep regretting that at such a young age group, I have salvaged her with a reverse shoulder replacement. But at some point of time, we are going to brace the eventual revision case. What is important is we've managed to give her a decent external rotation compared to the fact that she had minus 30, we've come out to plus 15. That gives them some form of functional movement. But it's very difficult in the absence of greater tuberosity to give them any form of rotations. Just a brief about the approaches. Because you're dealing with trauma, invariably these are 4-part fractures, complicated elderly age group. I would always jump into a deltopetal group. I'm not the adventurous one who would recommend a deltoid split in such patients. There are surgeons who would do a deltoid split for a plating for such patients, and that's reasonable if they're experienced enough, but you need to worship the axillary nerve and know your anatomy so that you would want to expose it, see it, and then go ahead. It's an extensile approach, and especially in a complex case like a reverse shoulder for 4 parts, it's better to stick to something that you're familiar and that is extensile. So are there challenges? There always are. This is a 72-year-old diabetic, ischemic heart disease, had a complex 4-part fracture, very osteoporotic. It kept plating as an option, but I quickly jumped into a reverse shoulder. What I was pleased to see was the greater tuberosity heel in position, and that's a big achievement to providing rotations and full function. I'm pleased to say uncemented prosthesis, he did very well. Till a year and a half later, he fell off his bike, which he was driving, and came up with this. So an uncemented prosthesis, and they fall on the same hand. And this is a major challenge because you want to retain the prosthesis and at the same time ensure everything goes well. So we've done a plating, and instead of using conventional cerclage, metal cerclage wires, we've used the Arthrex fiber tapes, which come with a device where you can tighten them and they look elegant. And so you've got screws only in the distal part and not in the proximal part. And you will see that he's had a reasonable restoration of movement and rotation. So we've been able to salvage his original prosthesis, but these are features that you can. So message going out here is in population that is unstable, who have a poor balance such as Parkinson's, Alzheimer's, I'll be very reluctant to do this. So if they have a fall propensity, then you have to think 3 times before you consider offering them a reverse shoulder replacement. So this is about a 6-month follow-up. He's now 2 years out since his revision reverse shoulder, and he's had a decent range of movement. But what I'm pleased is to provide them an external rotation. Achieving good amount of rotations after a reverse shoulder is not guaranteed, and there's only that much that you can do. So My recommendation is ensure that the greater tuberosity heals, and we'll deal with that a little later. Try and repair the subscap or the lesser tuberosity back in position. Your releases are important. And I think it's very important to have their native version restoration. Many surgeons will use a fixed 10 degrees version, but I'm one of those who would recommend the native version restoration for a reverse. It is again a controversial topic, and I completely accede to that. But what I'm alluding to is you try to restore their anatomy, they should get back their restoration. So I made a big hoo-ha about greater tuberosity, and it's not easy. It's important to understand that the 135 degree stems have a higher healing rate, as from this paper from the John Steinbeck and Tokish Staber. Post-op abduction is highest with a 155 degree implant, but the rotations are very poor. The deltoid contour is very poor. In terms of forward flexions, they are similar. The constant scores are similar between 135 and 145 stems, but the healed greater tuberosity has without doubt the best function in terms of forward flexion and external rotation. So that's a challenge we need to ensure, whether you're doing a hemiarthroplasty or a reverse shoulder. So what we recommend is, number one, you're dealing with trauma. You cannot expect to do a greater tuberosity repair on a smooth steel stem. So use a fracture stem all the time. You should have configuration of fracture stem where there's a nice micro mesh hydroxyapatite coat on the proximal one. You need recesses like here where they allow the circlage sutures to go through without attrition. And you should have your trial reamers match up with them, because height estimation in a trauma situation is completely different from doing a reverse as in a cold case. So we improved our tuberosity closure with two things. Number one, Mark Frankel paper on the circlage wires, and number two, on the niece suture. So after we use the niece knot, it has improved our tuberosity healing rates, and I have not lost a tuberosity since we combined these two techniques. So you can allude to this Mark Frankel paper in 2002, and it's an excellent paper. It has changed my practice significantly. So apart from the GT2 shaft sutures, LT2 shaft sutures, you need two sutures going around which will embrace the tuberosity. So it's an orthogonal fixation. And we tie the sutures with the niece knot. So that's a very robust knot. It's a dynamic locking knot. You don't need to hold it with your forceps. So this is another patient. She's elderly. She's 72 years old, osteoporotic, went in. This was an adventure that was rather a misadventure. And you can see everything's fallen apart. At this age, it's again not optimal to offer revision surgery and second surgery for these patients. So we've gone in again. We use an uncemented implant fracture stem, and getting the tuberosity to sit there is again a challenge because you're doing revision cases. But it unites, and if it unites, then you kind of get a reasonable function on these patients. But these are lessons in learning that you need to know which patients to fix and which patients to replace. Again, hemis are not appropriate for this kind of population, knowing that the cuff is going to be poor, their bone quality is going to be poor. In this paper from Mark Frankel's table, comparison of fixations versus hemiarthroplasty with reverse, the interesting thing was the range of movement between all three groups were fairly similar, nothing significant, but union rates of the tuberosities in this, contrary to what we believe, the fixations were much higher, probably because they're using the Frankel techniques. But resurgery rates in these patients were highest in the fixation group. So you must understand this, that 17.5% resurgery is unacceptably high. Reverse shoulders had the least 6.6%. So again, the message going out here is when you have a compromised patient, comorbidities, you want one surgery. Elderly population, just do a reverse. This is one of my patients, 72 years old, female. She came to me at different time intervals. 2016, she came in and she was about 69 that time. And we did a fixation on her left side. We were happy to have it healed well, reasonable movement. And since she came a year later, she was known osteoporosis, hypothyroid. We put her on all the osteoporosis treatment, including the teriparatide injections. But the second time she came in later, a year later, we decided we'd do a reverse shoulder because it was a dominant hand. And she was not quite happy with the fixation side. And when asked recently which side she would prefer, and she she favored her reverse shoulder replacement side, that's the right shoulder, than the fixation side. So that's interesting. Now, we also need to know when not to do a reverse shoulder replacement. So even if it's a 80-year-old patient with a two-part fracture, I don't see any need to do a reverse shoulder replacement there. A fixation would still work as long as the cuff and the muscle tendon attachments are intact. And when tuberosities are not involved, I'd be very loath to do a reverse shoulder replacement. Certainly, I wouldn't do it to the younger patients if they come in primarily. But if you have a patient, like I said, a Parkinson's, dementia, anybody who's a fall propensity, try not to do a reverse because that will lead to a very major complication where they do fall back again. Just digressing a little before I finish off, that understanding that there are other options in patients who are younger at 59, I would do something like an intramedullary fixation here and still save the patient's head and still get a very good range of movement and function. She's almost back to normal. So there are options here. So just finishing before the minute, understanding that there is, we have moved on to the HoloLens assisted shoulder replacement. So we have this holographic assistance when we are operating, and that gives me a much better picture, a 3D hologram alongside. And so we understand the fixation and the clinoid orientation, especially for ensuring that we get a zero version there. And this is probably the new technology where we'll have 3 different verticals in terms of the pre-op softwares and the HoloLens technology and the navigation, and they will eventually merge to give us a very good outcome. So this is a well-cited paper from Forsada where they compared the reverse shoulder replacements with hemi follow-up. Clearly, the reverse had a much better function in terms of UCLA scores, in terms of forward flexion 120 versus 79, abductions were 112 versus 70, but the rotations were worse than the hemiarthroplasty. So we have to be aware that the reverse is not a panacea. But this paper alluded to 70-year-old patients. So hemis in younger patients are still going to be good. This paper spoiled everything, and this paper and Pascal Boileau's paper said that hemis are bad, and that's why many surgeons went away from a hemi. But in a younger patient, I would still go ahead and do a hemiarthroplasty. So in conclusion, I would say that anybody who's 75 and above, you have a complex fracture, GT is displaced, I would use a deltoprotector approach, always a fracture stem. The tuberosity reconstruction, I've said, use cerclage and the knee knots. And it's a very reliable and replicable technique. Just 10 seconds on this, another reference that I put in here from Mark Frankel's table, Journal of Shoulder Elbow Surgery 2018. They looked back at all the proximal humerus fractures and reclassified them, blinding the senior colleagues, and asked them what they would do to if they were presented with this fracture with all the clinical details. And only 67% of them agreed on what was done. But in those patients that there was an agreement, they had a much better function, whether it was a plating or whether it was a reverse shoulder replacement. In those, there was not an agreement. Those patients didn't do well. So again, we don't have a 99% agreement between all of us, and we would approach it differently. But when it comes to somebody who's 75, you still have a very good option here. And I've tried to clearly give my clear indications on when I would do a reverse shoulder replacement. Thank you very much for your patience.
Okay, thank you, Dr. Ashish. That's very impressive lecture about the RSA or the proximal humerus fracture. So before we jump out to the discussion, I will divide 3 parts of the discussion into first the approach, second the intra-op tips, and the complication. So let's move on. When to choose the correct approach in treating proximal humerus with a primary RSA? Because I think most of us are rather sold out on one approach. Rather you are a deltoid split guy or lady, or deltopectoral lady or guy. So but not all the prostheses on the market are designed for, let's say, deltoid split. And Dr. Minoo here is also concerned about whether the axillary nerve is at risk when you do a deltoid split. So would you like to have a comment on that?
Very good question, Erica. I think when it comes to fractures, I'm always deltoid split. And you must take this from me because I started as a deltoid split surgeon And for the first 3 years of my practice, I thought the deltoid split for the reverse was the answer to global warming. And then slowly warmed up to the idea, and I had discussions with very many seniors who were deltopectoral surgeons. And I said the dislocation rates were higher with deltopectoral. And then they told me that most of the complications will be done deltopectorally. And so invariably, it's not a fair comparison between deltopectoral and deltoid split. So when it's trauma, it's deltopectoral for sure. And when it's an elective case and I have a prosthesis that is designed for deltoid split, I am actually half and half. If it's a straightforward cuff tear arthropathy, I prefer the deltoid split is much faster, save the subscap. But stick to your approach that you know. When it's a reverse shoulder replacement, if good in your hands, don't change just because I have said this. But knowing that you're dealing with a complex entity, you need an extensile approach. You want the tuberosities coming down. You want a good exposure. Use the deltopectoral approach.
Okay, excellent. Now move on to the next one. So intraoperatively, it's not very easy to know where am I when I'm dealing with fracture or the arthroplasty case. So how to determine the correct version in trauma case? Landmark is usually, I'm helpless intraoperatively mostly.
Yes.
Please comment.
Yes, again, a very intelligent question. I was hoping you wouldn't ask me for this, but we make a lot of noise about version. And till the first 7 years of my reverse shoulder practice, I started in 2010 when it was introduced in India. I used to use the conventional technique where you used either 0 or 10 degrees version. And then we sat down and we researched and we found that consistently the rotations were not up to the mark. And over the last 5 years, we did actually a brilliant study with our fellow where I was compelled to do half of them native anatomy and half of them were conventional 10 degrees. Our native anatomy versions have done much better in terms of rotations, and you've seen some of those videos. The challenge is in trauma where there is absolutely no landmark. So there are 2 tips that I can share with you. Number 1, when you look at the calcar from top, so you're looking end on the shaft and you're seeing the marrow down, the marrow or the circumference of humerus is not round. So it has a little bit of prominence here on the medial side. This is what you see. So if you see a little bit of elevation, that's your calcar, that's your medial tip. And that's where the center of the medial process you will head to. And you need to double check because this is not an objective landmark. The medial epicondyle will always face the center of the head of humerus. So you build both of these together, and these are a little subjective, but when you build both of the landmarks, you will invariably be within 5 degrees of your process. If you've really done a good release and if you've got the correct version, both your tuberosities, when you bring both of them together, they will sit in and meet in the intertubercular groove. That the fact that your tuberosities are sitting in here, and even if they're abducting, they're holding on, tells you that 1, you've balanced them correctly, you've not overstuffed the joint, and you've got a good version. And so even in trauma, you will get a good rotation.
Okay, so we have 3 tips here. The medial prominence, the medial epicondyle. I guess you drape the arm here, just like Dr. Vrancic when she showed us in the slides. And we have the lesser and greater tuberosity brought together to you. So talking about the tuberosities, in your slide, you have pointed out that the GT and LT reconstruction is the key. Any tips to avoid tuberosities floating? Because sometimes it doesn't look very good intra-op, especially if you use a C-arm. I'm not ashamed that I use C-arm a lot intraoperatively. Your comment, please, sir.
So, Erika, we are on the same level playing field because I use the C-arm a lot because I have absolutely no ego about that because whatever you do in the theater is done. You cannot revise it afterwards. Yeah. And sometimes there's a big discrepancy between what you see in trop and you see the next day's x-ray and you're like kicking yourself and you're trying to hide it from your fellow. The C-arm is going to help us ensure and put it in different positions for sure. The standard repair technique is GT to shaft, LT to shaft, and then GT to LT as a rotator interval closure. But when you involve the circular sutures, try not to forget that. So they go one superior, one inferior, and they go around. So I never ever use the holes in the prosthesis because I don't believe tuberosities easily will heal to prosthesis. That's why I always drill holes in the shaft of the humerus. I just need two, one anteriorly for the lesser tuberosity and one on the lateral side. But the suture that goes through the anterior one mates with the tuberosity posteriorly. And the suture that goes laterally mates with the lesser tuberosity because that's the direction of traction. So that's where they meet. It's very common sense to put LT into the anterior hole, but then that's not pulling it into its native position. So these small tips will help. And do a primary and without tying a knot, see it on X-ray, see how it is sitting. If you see the C-arm, I showed you some of the views on C-arm. If it sits as if it belongs there, it's as if it is like it's pre-op state, then it's going to survive its length post-operatively.
Okay, we have a last question here about the complication. The literature has shown that RSA has higher complications, such as here we have some concern from the floor that saying neurological injury may be higher than RIF. Would you be agree? And secondly, is scapular notching a serious problem in your opinion, sir? Please.
Right. So let me take the first point about complication rates. To be honest, published literature, complication rate with reverse shoulders are far less than fixations. We are dealing with elderly population here, clearly. So the plating, I must say that the lock plate has been a great disservice. It made everything look easy. So everybody thought the lock plate is easy and they started doing it willy-nilly, not understanding, as Sindy said, that it's a globe. And so very commonly the saddest complication, the most common complication of the lock plate is screw penetration. And I've had patients who've healed proximal humerus fractures, but the screw penetration has destroyed the glenoid and I had to do a reverse shoulder as a revision. And that's a pity because the plate has achieved its primary objective, but brought in a much more dreaded complication later on. Neurologically, I don't see a problem at all with reverse shoulders. Our complication of reverse shoulders very less. The complication of neurological affection with proximal humerus plating is much higher with the axial nerve, especially those who are using a deltoid split approach. There's a lovely paper 2010 from Children's Shoulder Elbow Surgery. I forget the name. I'll put it on the chat group. Where they did EMG studies for all their deltoid split approach. It was only 10 patients, and they found EMG abnormalities in all of them. 70% of them recovered, 10% had partial, but 12% had complete permanent axial nerve injury. And that's why I'm a big advocate of deltopectoral for proximal humerus fracture. It's a safe approach, and I'm not saying it's without blame, but if you're doing deltoid split approach, you need to have the experience and the gumption both together to be doing. Now, your second question, I think
it's about the scapular notching, but if I may, sir,
scapular notching. Go on.
Time constraint, would you be happy to answer in the panel discussion?
Yes.
Because we
Yes,
can
I agree.
distally to Dr. Sofian. Thank you, sir.
Yes. Yeah.
Thank you very much, Dr. Erica. Now I'd like to introduce our last speaker for this session, Professor Therachai, and he will be speaking on the minimally invasive plate osteosynthesis technique for humerus shaft fracture. So, Professor Therachai, please.
Thank you very much. Thank you, Marinis and the APOA Trauma Society for inviting me. Can you see my slide?
Yes, sir, it's visible.
Yeah, and the sound is okay?
Yes, the sound is perfect, sir.
Okay, could we come down a little bit? Maybe not so difficult as Ashish. This is just the shaft fractures. First, we will start with the evidence of the operative treatment for humeral shaft fracture. Which one? How to select the patients? I think the mid shaft and the distal shaft is the problem for us. And what is the implant of choice? How to approach? And I show you many case demonstration around the approach around the humerus. First, we start with the literature. We know about Mipo, ORRF, and the nailing for humeral shaft fractures. This is the meta-analysis in 2016 and 17. The conclusion from both of these literature is the clinical outcomes. The Mipo has significant better outcome than the nail or open reduction. All complication, open reduction and nail groove has significant higher complications. And iatrogenic injury of the radial nerve is more common in open reduction. It's strange for us that in Mipo you didn't see the nerve, but why? We have less complication of radial nerve injury. And last one, the plate is better performance in preventing complication than intramedullary nail. So it's like plate is maybe better than the nail from the literature. Today we talk about the Mipo. So I'm not telling you that the plate is better than the nail, but from the literature, some of now we prefer the Mipo. Now, look at the case. This is simple humerus shaft fractures, no nerve injury, just a simple transverse fractures. What will you do? This is my case. I think it's since 2004. Yeah, at that time, the Mipo is like, we do the Mipo, right? And look here. This is the incision, and this is the X-ray. What happened? If you look carefully, this is simple fractures. And you see the fracture is not anatomically reduced. You have some gap. That means you should have some malrotation. In this case, it ends up with delayed union. And finally, we need the bone graft. What does it mean? Yeah, simple fractures. Open reduction is simple and reliable. So be careful. In simple fractures, don't try the Mipo. Now this is a case of transverse fractures. What will you do? Now for me, I recommend that if you have these fractures, just open it. Do the classic approach. This is just the anterior or anterolateral approach of the humerus. This is simple fractures. Don't worry about the non-union. Yeah, you see the musculocutaneous nerve. You split the brachialis. Yeah, and you see the fracture. This is just the simple one. You see this fracture is here and just the compression plate, right? Compression, and this is just the classic open reduction, and finally it's healed. So simple fractures. Yeah, this is an article to confirm that time to union in absolute stability and relative stability in simple humerus shaft fractures. If you look here, they evaluate the absolute and relative stability in 70 simple fracture shaft. The radiographic union is lower in absolute stability group. Yeah, non-union, 2 cases in relative stabilities. So from this literature, they conclude that simple fractures on type A, you should treat it with the absolute stability construct. Relative stabilities should be reserved for multifragmentary. Choose the right patient. Ideal indication for the Mipo, like in this case, you see, it's a gunshot injury, and you cannot count how many pieces, but simple fracture, comminuted fracture, you just bridge the fractures. Don't worry, just bridge it. Yeah, this is a case to show you. Yeah, we published since 2005, and the danger zone for this anterior approach 2010. Yeah, just the anterior Mipo approach. Don't touch the fracture zone. The problem is, how do you know the rotation of this humeral shaft? Okay, if you look at the X-ray carefully, this is the position. First, you check the X-ray. This is the AP of the shoulder. How do I know? You see this, the lesser tuberosity here. The lesser tuberosity here is in the center of the humeral head. This is the AP of the proximal. And then you check the X-ray. This is the AP of the humerus of the elbow. Everybody knows. So more or less, this is the correct rotation. Oops, what happened? Sorry, it doesn't move. Okay, now this is the anterior Mipo. Distal incision and proximal incision is here. You see the distal incision, this is the musculocutaneous nerve. You split these muscles. Sorry. The slide are not advanced. Just a moment. I don't know what happened. Can you see my slide?
Yes, Professor.
We can see.
Yeah, it's still, the slide is still, it's not moving.
Just a moment. I try to forward, but it doesn't move. I don't know why. Okay, now it's moving. Then we make a tunnel from distal to proximal under the brachialis. And then you slide the plate in. Now you check the X-ray. This is the AP of the elbow, right? The plate lie on the anterior of the humerus. And this is the AP. If you move the C-arm up a little bit, then you see the humeral head. That means now we should be in the correct rotation. The length in this case, it doesn't matter because it's comminuted. You can make a little bit shortening. Yeah, and this is the final X-ray. You can check AP and lateral, and this is the final fixation. The slide doesn't move. I'm sorry. Let's try again. And this is the post-op. Yeah, you see the correct rotation. Yeah. And oh, sorry, it doesn't move again. Okay, this is 6 months. You see the callus bridging. Now we have another case. This is the distal shaft of the humerus. How we fix it? Because the distal is very short. How we approach? I'm not sure what happened again. Okay. Anterior or posterior approach, because it's very short. I'm sorry, it doesn't move. Okay. This is the reverse philos, just published last year. Yeah. The technique is you use the anterior approach as the normal straight plate, but in this case, the distal part you can fix with more screws. Yeah, and if you look from this intraoperative X-ray, in the distal part, you can fit with at least 6 or 7 screws from the head of the philos. Yeah, and this is the X-ray post-op. 6 months, the callus bridging, and you see the very good functional outcome. Now, another option is the anteromedial approach of the humerus. Because sometimes if you have the wound on the lateral and you don't want to touch it, this is another option. It's possible. And you can put the screw from medial to lateral. That's mean, yeah. Don't do the percutaneous because you know this is the denture zone. You have the neurovascular on the medial side. But if you work under the brachialis, it is safe. Yeah, this is the X-ray to show you that the medial to lateral screw. This is long enough and provide more stability. The advantage of this anteromedial approach, you see the smooth surface of the humerus, and this is the very nice hidden scar on the medial of the elbow. And in the case you had the lateral soft tissue compromise, this is another option. Yeah, you can go from the medial epicondyle in the distal part, and the proximal is the same as the anterior Mipo. Yeah, you can slide the plate in. Yeah, this is a case just to demonstrate. Yeah, we just published 2 years ago, anteromedial of the Mipo. Cadaveric study is possible, and this is the intraoperative X-ray to show this is the medial, and you can make a bypass bridging here up to the proximal of the humerus under the brachialis and under the neurovascular bundle. And this is the bridging plate of the humerus. Finally, 6 months, 12 months, it's healed by the callus. And this is the function of the anteromedial Mipo. This is another case. It's quite very low in the distal humerus. He got a partial retinal palsy, but he has some part of the nerve function. How to approach? This is a very low. However, if you look carefully, this is a low, a little bit longer lateral column. That means this should be the bone stock for the fixation. Yeah, after initial treatment, you can do the Mipo with the post-ciliary approach. Yeah, we just published 2018 again for the danger zone and the nerve and structure atlas. The patient in the prone position, yeah, you mark this is the radial nerve, and this is the lateral epicondyle. You can go to the lateral column, it's just like the distal humerus approach. And here, the proximal incision is quite a little bit high up because you have to go in between the long head and lateral head of the tricep to identify the nerve. You have to see the nerve from the posterior approach. Yeah, this is the lateral distal incision. This is very easy one. And now you go up to the proximal incision between the lateral head and long head. Now, when you split these two heads, you will see the radial nerve and the profunda deep humeral artery together. Then you identify it and you hold it up and prepare the tunnel by using this tunneling instrument. Yes. You lift the nerve up and then you pass the tunneler up to this posterior of the humerus. Yeah, then you check the X-ray. You slide the plate. This is the extra articular distal humerus plate. Yeah, check the lateral on the distal first, and then on the proximal you check the X-ray. The plate is in the center. Yeah, and now this is the final fixation, the distal part, and this is the proximal part with the radial nerve is here. Yeah, and this is a post-op X-ray. Yeah, he has partial nerve palsy. "5 months, this is a fully recover, and you see the fracture healed by the callus. And this is 7 months, complete function. This is another case. The last one, 20 years old, ladies. She had the radial nerve palsy and the spiral of the distal humerus fractures. How to treat, or do you want to explore the nerve? Now, I use the ultrasound a lot in every case that you have the radial nerve palsy. The role of the ultrasound, you can detect the radial nerve. In this case, if you look carefully, this is the cortex of the bone, and this is the radial nerve. That means you see the radial nerve is continuity is here. However, the spine of the bone, yeah, is on the nerve here. So you just go in and just release this nerve, it will be fine. This is another case. Yeah, we look at the ultrasound. You see the bone fragment, the cortex, but you cannot see the nerve, right? Intraoperative, this is the laceration of the radial nerve. So if you cannot see the radial nerve by the ultrasound or discontinuity, for me now, I use the as an indication for the early exploration of the nerve. And this is a publication in 2019. They used the ultrasound to evaluate the condition of the radial nerve. 92%, right, concordance between the ulnar nerve and intra-op finding. So they said that ultrasound is an effective diagnostic tool in evaluating radial nerve injury. Decision making, if nerve laceration or entrapment, then you need the surgery. If you see the continuity or just the neurapraxia, you can wait just like a non-operative treatment. So in this case, yeah, we know that we have to release the cortex from the radial nerve. Another option, so we can use this anterolateral incision to slide the plate in, and at the same time, we explore the radial nerve here, yeah, just to reduce the bone fragment. Yeah, with this anterolateral incision, this is the radial nerve. Now we hook up the radial nerve already, and then we slide the plate in. This is the pre-contour, anterolateral. You have to pre-contour it first. Yeah, and this is the proximal incision. It's the same as the anterior approach. Yeah, make a tunnel. Slide the plate in, and now you check the X-ray. This is the distal fragment and proximal fragment. Yeah, finally, distal and proximal fixation. And post-op day 1, yeah, the patient can move the arm, the elbow actively. And this is 1 year. Yeah, the radial nerve recover, the fractures heal. So in summary, humeral shaft fractures, we can do the Mipo. However, if you have mid-shaft or distal shaft simple fractures, compression plates still now the option for me. If you have comminuted fractures, yes, you can do the bridge plate by the anterior approach. This is the simple one. If you have the distal shaft, you can use a reverse anterior philos. Yeah, you can use anteromedial. You can use posterior. I think it depends on the experience you have. Knowing the anatomy is important. If you know the anatomy, you can go around the humerus. Thank you for your attention, and sorry for the slide problem. Thank you very much.
Thank you very much, Professor Therachai. Indeed, a very, very enlightening talk. And I think the advent of going around the humerus is just experience in knowing the anatomy that you have beautifully showed that you can have an anterior Mipo, you can have a lateral Mipo, a medial Mipo, or the posterior Mipo. So, so there's only one question that I see from the audience, that do you still use the DCPs for your Mipo techniques?
Yes, I still use the DCP, but if you use the DCP with the anterior approach, the problem is you have to sit on the anterior crest of the humerus. That means sometimes when you start drilling, the drill tend to slip to the medial or the lateral side, right? So this is one of the problem. Yeah, if possible, you can use the LCP. It will be easy because the plate can be floating on the anterior crest of the proximal humerus. Yeah. If I have to use this the DCP, I will just drill the cortex first. I see the crest and then I drill on the anterior cortex. Then the plate will not move medial or lateral.
I think there is one other question that do you ever use the posterior approach, the comparison between the posterior versus the lateral approach? So I think they're asking about the true posterior approach for the fixation of your fracture from the posterior side.
What is the questions?
I think they are asking that do you still use openly the routine posterior approaches, or do you have shifted back to your Mipo approach that you have actually told us in the posterior humerus fracture fixation?
If you have the simple fractures, right now, I think simple fractures, you can use the open reduction. That's more easy, and you'll have less X-ray exposure. Yeah, just do the compression. Yeah, but in comminuted, you cannot open it. Then you can just bridge the fractures.
Okay, thank you very much, Professor Therachai. So this concludes the questions from the audience. Now, as previously told by Dr. Jamal, I think there's, if I may go back to the questions that were left for Professor Minoo Patel. So, Professor Minoo, can you hear me? Can you?
Yeah, I can. Sorry, my Zoom froze, so I had to get out and get back in.
So there were two actually questions which are left for you. It said that you actually spoke about the literature in a beautiful way regarding the paradigm shift that we have actually seen for the fixation of our clavicles. So it is the question is, in literature, why do recent studies report a higher non-union rate as compared to the earlier studies that we used to have in the literature?
So look, the person who's done a lot of work on this has been my colleague Martin Richardson, and we've done most of our studies together. Martin has been saying since the 1990s that the literature has been interpreted wrongly, that clavicles always had a higher non-union rate. We just turned a blind eye to it. And even now, I mean, I have a foot in each camp, in the trauma camp and in the upper limb camp. And the number of times when you get a non-union, that shoulder surgeons will say, oh, just leave it alone. You know, it's not pain-free. You can leave it alone. Like that infected case that I showed you, he was advised to just leave it alone. And he said, well, he's a young guy. He likes going cycling and he had no strength. And so we tend to sort of ignore those sort of complications. And the non-union rate was always around about 15 to 20%. And the real proof of the pudding was when the Cochrane group, who are the most conservative group, when they came out with their figures, talking about an 18% non-union rate, you really took notice about it.
Thank you. I think that was the misinterpretation was the thing we were actually looking into that. So another question that you mentioned, anterior plating versus superior plating. Do you think is there any superiority of using an anterior plating versus a superior plating?
Look, I think, and this is something that's come out with Mohit Bhandari's group as well. They found that superior, or the so-called anterior superior, where the plate is slightly bent, is better. And this is the caveat that I gave with our unicortical plates as well. So what happens is when you have an anterior plate, all your cantilever forces are taken by the screws, right? Whereas if you have a superior plate, the cantilever force is taken by the plate. Your screw just holds the plate together. Whereas rotational torque, there is no difference, whether it's an anterior plate or a superior plate. But for abduction, the cantilever forces, the superior plates are by far much better than anterior plates. And that's why I think the anterior plates are an issue. They came about because people felt that the rate of plate removal would be lower, but that's not true. There was also some suggestion that the rate of neurovascular injury would be less, but as Greg Bain has shown, the neurovascular structures are at risk no matter whether you have posterior penetration of the cortex from the anterior plate or the inferior penetration from the superior plate, the neurovascular structures are still at risk.
So one last question, that how do you actually manage brachial plexus symptoms due to malunion that has already happened because of the malunited clavicle?
How do I manage with trepidation?
The brachial symptoms, yeah.
No, with trepidation,
Yes.
with fear. So a couple of important issues. So I've had now a couple of cases where people have had brachial plexus exploration because of so-called neurological symptoms. And actually what the patient has had in both instances is a pseudoaneurysm of the artery. So it's good to be very careful to differentiate between brachial plexus symptoms and what can be called as thoracic outlet syndrome. So that's one important thing to do. So basically do thorough investigation, nerve conduction studies, brachial plexus MRI scans, and also CT angiography. If that is all under control, then I basically use my colleagues with, I've done cases where with both a neurosurgeon as well as a vascular surgeon present, and we explore it. And there's another word of caution. A couple of us, myself included, and a colleague of mine, Greg Hoy, when we have shortening, and you want to, with a malunion where the patient wants it to be corrected to get proper length. Girls don't like it when one side of the shoulder is smaller than the other. Very, very careful. We've both had cases where we've lengthened it and given them a brachial plexus traction, and we've had to take them immediately back to theater and said, no, this is too problematic, go to shorten them again back to where they were. So it is an important issue.
Thank you very much, Professor Minoo. These conclude all the questions. So I think with the advent of time, it's back to Professor Meredith for the session.
Yes, no, very good. Thank you. I will ask one question though, Therachai, because it was asked in the questions a couple of times. So very brief answer. Do you think there is still a place for nails in the management of humeral shaft fractures?
Yes. Now I think the nail has changed. It's a game changing. Yeah. If you look at the percutaneous technique, I think sometimes we have the pendulum may swing back again. Yeah. If you have the percutaneous, then maybe Sindy, you will love it because this is just passing the muscle. It's not the load of the cuff now. Yeah. It's possible, Marinis. In the future, I think it will be back again.
Can I make a comment, Marinis? So there have been a couple of good papers now going through the rotator interval. So you don't even have to go through the muscle. You're going in the rotator interval, and that is really going to change the way we look at humeral nails.
Yeah, good. Yeah, I thought we would just mention that because there have been some modifications in the nail design, which the pendulum is slowly swinging back. So, look, I'd like to thank everyone. For those that have joined us late, I'm Marini Papyrus, and on behalf of the Trauma Society and obviously all our speakers, I'd like to thank all of our audience for their time, and we hope that you enjoyed the session today. I'd like to thank all of our speakers, and I think you'll join me in thanking each of them. Saeed Thani, Minoo Patel, Sindy Vrancic, Ashish, Babhulkar, and Therachai. I think they've provided us with some great insights, some great questions, and hopefully it'll influence your practice and the way you manage these types of injuries. I'd also like to thank our moderators. I think they've done a terrific job. Thank you, Erica, Colleen, Dennis Yee, and Mohammed Sufian for all your hard work today in keeping everyone to time. And once more, I'd like to thank the APOA for helping us with this educational initiative. I wish you all a good day, a good morning, a good afternoon, or a good evening, and we'll see you at the next one. Have a good night. Thank you for your participation.
Thank you.
Thank you. Thank you.
Thank you, everybody.
Thank you.
Thank you. It was excellent.
Recording stopped.
Ashok sir, I can end the meeting. Hello, Ashok sir.